Hello, I am Professor Hosam Hasan El-Araby, Head of Cardiovascular Medicine Department in Asyut University. Today I will speak about the second lecture about what should cardiologists know about new anti-diabetic medications. First, we will discuss the relationship between diabetes and cardiovascular diseases. 2/3 of deaths in diabetes are attributable to cardiovascular diseases. When you look to this slide, you will find that diabetes doubles the risk of all vascular events, including cerebrovascular events. You will see the odds ratio is ranging about 2 in these endpoints regarding coronary heart disease, coronary death, non-fatal myocardial infarction, and even cerebrovascular diseases. Regarding the pathophysiology of cardiovascular disease and diabetes, there are several mechanisms by which diabetes can cause cardiovascular diseases. These can include oxidative stress, inflammation, insulin resistance, obesity. All of these can lead to atherosclerosis and finally major acute cardiac events ending in with cardiovascular death. Heart failure is another mechanism by which diabetes can lead to finally cardiovascular death. Type 2 diabetes can cause cardiovascular and renal diseases. It can affect the pump, the plumbing, and the filter. The pump, which is the heart, the plumbing, which is the blood vessels, and the filter, which is the kidney. First, we will discuss the atherosclerotic cardiovascular disease, the affection of the plumbing system. The mechanism by which coronary artery disease occur in diabetes include hyperglycemia, increased fatty acids, insulin resistance, leading to oxidative stress increase, which finally lead to vasoconstriction, causing hypertension and vascular cell growth factor release, and inflammation by increased release of cytokines and chemokines, and increased tissue factor. Plasminogen activator inhibitor 1 and decreased nitric oxide can lead to increased thrombosis and hypercoagulable status and platelet activation. All of these are the mechanisms by which coronary artery disease and acute coronary syndromes can occur in type 2 diabetes patients. This is a very important slide because it shows the relationship between acute coronary syndromes and death in patients with type 2 diabetes undergoing PCI. Patients with diabetes and STEMI have the highest rate of death compared to patients without diabetes. This is followed by patients with diabetes and non-ST segment elevation myocardial infarction. This is followed by absence of diabetes with STEMI, and the lowest rate was with absence of diabetes and non-ST segment elevation myocardial infarction. So STEMI and STEMI with diabetes have the worst prognosis compared to those without diabetes mellitus. When you look to this slide, it's a time factor from 1998 to 2013. You will see in this slide that death from cardiovascular disease didn't change between the matched controls and type 2 diabetes. The improvement occurred in both due to the improvement in the technology and improvement in the medical care of patients with cardiovascular diseases. But the difference between both groups didn't differ along this time. The same regarding, as you see here, death from coronary artery disease and hospitalization for cardiovascular disease. The same, it improved, but the improvement with diabetes was much more than in matched control, so the gap decreased. This is very important data to remember in diabetic patients. Second, we'll discuss heart failure, effect of diabetes and heart failure. Heart failure was the first manifestation of type 2 diabetes treated cardiovascular disease patients, and more often even than myocardial infarction following peripheral arterial disease. In this large cohort study, peripheral arterial disease and heart failure were the two most common first presentations of type 2 diabetes. However, myocardial infarction and stroke continue to be chosen as the primary outcomes of major type 2 diabetes trials as a part of MACE endpoints. and because of the seriousness of the problem. Heart failure can occur in diabetes by two mechanisms: atherosclerotic mediated mechanism through the occurrence of coronary artery disease and myocardial infarction, and atherosclerosis independent through the occurrence of diabetic cardiomyopathy, the effect of diabetes on the myocardium through direct inflammatory microvascular affection on the myocardium and causing the diabetic cardiomyopathy, a second mechanism for heart failure in diabetic patients. Diabetes can cause heart failure, either diastolic heart failure in 16% of patients, systolic LV dysfunction in 27% of patients, and both in 25% of patients. Only 32% of diabetics have normal left ventricular function. So we have two distinct types of heart failure in diabetic patients: HFpEF, heart failure with preserved ejection fraction, in which cardiomyocyte hypertrophy and cardiomyocyte fibrosis occur and increase cardiomyocyte stiffness, and HFrEF, in which there is apoptosis of the cardiomyocytes and necrosis and decreased cardiomyocyte shortening, causing systolic dysfunction in these patients. Finally, we'll discuss the renal diseases. Diabetes is the leading cause of chronic kidney disease. You should always remember that 42% of diabetics have chronic kidney disease. Diabetes can cause chronic hyperglycemia. Chronic high blood glucose can cause chronic kidney disease because of breakdown of the filtration barriers of reabsorption ability of the kidneys, and impaired glucose filtration will lead to loss of metabolites and electrolytes, multiple comorbidities. So this is a circle that can occur in type 2 diabetes patients. Chronic kidney disease is highly prevalent in type 2 diabetes. As you see here, it is 3 times higher in patients with diabetes than in the absence of diabetes. When you look here, you will find the prevalence of chronic kidney disease stage from 1 to 5 in patients with type 2 diabetes is consistent a long time. So it is higher in diabetics than in non-diabetics, with no change in the prevalence with time. When you look to this slide, you will find that the first comorbidity identified cardiovascular disease patients type 2 diabetes is heart failure in 24% of patients, and in 36% of patients it is cardiovascular disease. So there is a clear link between diabetes and chronic kidney disease. So diabetes can cause kidney affection and can affect the heart. All of these affections can be mediated via a common pathophysiology: sodium retention, hypervolemia, RAS activation, neurohormonal activation, inflammation, ischemia, and altered energetics. All of these factors can affect both the kidneys and the heart, causing dysfunction in both systems. Now we will discuss the cardiovascular outcome researches in type 2 diabetes and the new concepts in treatment of diabetes. The first part of what cardiologists should know about anti-diabetic treatments was discussed, and it included the standard treatment for diabetes mellitus, insulin, metformin, and sulfonylurea. Now you will look to this slide. It shows that the traditional treatment of diabetes with the control of diabetes, there is a decrease in the microvascular events in short and long term with the standard treatment of diabetes. Regarding the macrovascular complications of diabetes, cardiovascular disease affection, the improvement was shown in only few trials: UKPDS, ACCORD, and VADET trial, only on long-term follow-up. And the mortality was not improved except in UKPDS on long-term follow-up, and even it was worse in ACCORD trial on short-term follow-up. This was the main problem with the standard treatment of diabetes. With the rosiglitazone, there was an associated increase in the risk of myocardial infarction and increase in the risk of death from cardiovascular diseases, and this was of borderline significance and caused withdrawal of rosiglitazone from the market worldwide. And this caused the different societies, including the FDA, to recommend that any new anti-diabetic treatment should have safety trials regarding cardiovascular outcomes. The sponsor should demonstrate that the therapy will not result in an acceptable increase in cardiovascular risk, and pre-marketing pooled meta-analysis of data is mandatory for any new anti-diabetic treatment, and post-marketing safety trial is also mandatory. These are the new anti-diabetic drugs that we will discuss today. The first group is called incretin-based drugs. There are two groups of incretin-based drugs, DDP4 inhibitors and GLP-1 analogs, and SGLT2 inhibitors. This is the second group of new anti-diabetic treatments that will be discussed. These drugs performed different cardiovascular outcome trials starting from 2013 till 2019 to prove the safety and even more the beneficial effect in reducing major acute cardiovascular events in patients with type 2 diabetes. First, we should understand the pathophysiology of diabetes in the right way. With the ingestion of carbohydrates in meals, there is an impaired pancreatic insulin secretion. There is insulin resistance. There is a paradoxical increase in glucagon secretion and rapid gastric emptying. All of these factors will lead to hyperglycemia. In addition, there is an increased hepatic glucose production. The cause of increased hepatic glucose production is not fully clear. It is attributed mainly due to increased glucagon secretion and to insulin deficiency. But these are not these are not all factors causing increased hepatic glucose production. This is why patients with diabetes, despite deprivation of taking carbohydrates and sugars, they could have increased blood glucose level due to increased hepatic glucose production. This slide shows how DDP4 inhibitors improve glycemic control in patients with type 2 diabetes and how incretin-based therapy works. With the ingestion of food, there is a stimulation for secretion of two types of incretins from the GIT. These incretins are GIP, which is glucose-dependent insulinotropic peptide, and the second one is GLP-1, which is glucagon-like peptide. These two incretins act on the pancreatic islet cells of Langerhans, causing stimulation of beta cells for production of insulin. And insulin produced will lead to glucose increase in the serum glucose, fasting and postprandial, and increased peripheral consumption of glucose from the skeletal muscles and adipose tissue. At the same time, it acts on the alpha cells, causing decreased glucagon secretion, and this will lead to decreased hepatic glucose output. In the same time, GLP-1 act on the stomach, causing inhibition of rapid gastric emptying. All of these will lead to glucose-dependent reduction of serum glucose level. The most important term here is glucose-dependent, because all of this is dependent on the elevation of serum glucose by the ingestion of food. The problem here is that these incretins are very short-lasting, so they are break down in the circulation using a normally present enzyme called DDP4 enzyme, dipeptyl peptidase enzyme. With the introduction of DDP4 inhibitors, we can delay the breakdown of these incretins, increasing their serum level and increasing their action, causing the anti-diabetic treatment achieved with these drugs. Because it is the glucose dependent, the incidence of hypoglycemia is very low with this group of drugs. In addition, you can use GLP-1 analogs as injectable in a high dose. GLP-1 analogs as injectable can bring a higher concentration of GLP-1, even more than with the use of DDP-4 inhibitors. This is why they are more potent in reducing the diabetes and more potent in weight reduction than DDP-4 inhibitors. So GLP-1 enhances glucose-dependent insulin secretion, and glucagon secretion is decreased, and therefore hepatic glucose production, slows gastric emptying, and increases satiety, resulting less food intake in patients with diabetes, and appear to stimulate insulin gene transcription and insulin synthesis. This is why it is claimed that these drugs can lead to, on follow-up in animal studies, to increased beta cell production in the pancreas, regeneration of beta cells in the pancreas. The actions of GLP-1, unfortunately, it is rapidly broken, as we said, by DDP-4 enzyme, so we need DDP-4 inhibitors to increase their level, or need to be injected in the circulation after some modification in this series to make it more stable in the circulation. Incretin mimetics, glucagon-like peptides. These mimetics are not typically like GLP-1. They are analogs with some modifications to make it to survive longer in the circulation, or using DDP-4 inhibitors to inhibit the breakdown. These are the DDP-4 inhibitors: sitagliptin, vildagliptin, saxagliptin, linagliptin, and allogliptin. The cardiovascular outcome safety trials of these drugs. In 2013, we had SAVOR trial with saxagliptin that showed non-inferiority compared to placebo regarding safety. Allogliptin in examined trial, the same, no difference compared to the placebo group. And the TICOS trial with sitagliptin, the same. There was no difference compared to placebo regarding safety. To all of these drugs are proved to have cardiovascular outcome trial safety, and this is why they were approved by the different societies for use of diabetic patients. They are neutral effect regarding MACE, as you see here in this slide. It is clear, and even more, the Carolina trial showed that linagliptin have the same MACE compared to glimepiride, which is a secretagogue, insulin secretagogue, sulfonylurea drug. Compared to sulfonylurea, it had the same safety here in this Carolina trial. This slide shows the group of GLP-1 analogs. We will see that these drugs performed safety endpoints, showing that for ELEXA trial, for example, there is a non-inferiority compared to placebo. It is safe regarding cardiovascular outcomes. Regarding liraglutide, we are for the first time with an anti-diabetic treatment to have in the LEADER trial a drug that can reduce MACE. And this is a breakthrough in the treatment of diabetes mellitus. With the exenatide FREEDOM trial showed that there is no change compared to placebo regarding cardiovascular outcomes. And in EXCEL trial the same, it is non-inferior compared to placebo. While with the semaglutide in SUSTAIN 6 trial, we have again a reduction in MACE with the anti-diabetic treatment. With the dulaglutide, again, we had with the RAWIN trial a decrease in the MACE with the use of these drugs, with this drug compared to placebo. And with albiglutide, with HARMONY outcomes, we have again a reduction in MACE compared to placebo. So for the first time, we have a group of drugs with 4 trials having a reduction in MACE compared to placebo with the treatment of type 2 diabetes. GLP-1 agonists advantage, potent anti-hyperglycemic drugs, weight reduction, and less hyperglycemia. This advantage is expensive, injectable, causing nausea and vomiting. When you look to the trials, ELEXA trial, It is safe. P-value for non-inferiority is significant. For superiority, it is not significant. Leader trial, it is significant for non-inferiority and for superiority. Excel trial, it is significant for non-inferiority and borderline significance, 0.061 for superiority. Here we will look to the harmony, rewind, significant regarding MACE, like sustain 6 and leaders trial. So we have here cardiovascular protection data. Regarding heart failure, only harmony trial showed significant improvement regarding cardiovascular outcomes, regarding heart failure as a part of cardiovascular outcomes. Now we will discuss the last group with SGLT2 inhibitors. The kidney supports 3 key functions in glucose handling. The kidney contributes to 20 to 25% of total body glucose release in the fasting state via gluconeogenesis. And this depends on free fatty acid oxidation as the main source of energy. The second part is utilization of glucose in the renal medulla. It accounts for 10% of the total glucose uptake in the body in the fasting state. And lastly, reabsorption of glucose in the nephrons, a return of glucose in the circulation via reabsorption of glucose that occur convoluted tubules. The filtered glucose from the nephrons is reabsorbed again in the proximal convoluted tubules, as you see here in this slide. Now, membrane proteins that regulate transport of glucose across the serum membranes are 2 types, SGLT2 type and GLU type. What is the difference between the 2 types here? The difference is illustrated here in this slide. GLU T family facilitates glucose transporter by a passive bidirectional transport. There are 13 members of this group, GLUT1 to 12, and myo-inositol transporter. These are present in both the kidney and the pancreas. SGLT family, it is a sodium glucose co-transporter. It transports glucose with sodium and on the reverse potassium retention. It is active unidirectional transport. This group has 6 members, SGLT from 1 to 6, as you see here. 1 is present in the brush border of the small intestine, and the S3, the third segment of the proximal convoluted tubule. SGLT2 is present in the proximal convoluted tubules, first and second segments, as you see in this graph. So, by the first segment here, the absorption, the transport occurs 1 glucose with 1 sodium, and in the opposite direction 1 potassium is returned. While in the third segment of the proximal convoluted tubule, 1 glucose and 2 sodium molecules are lost. In the same time, 2 potassium are retained. So more sodium loss and more potassium retention with SGLT1 in the distal third of the proximal convoluted tubule than SGLT2, which is present in the first and second parts of the proximal convoluted tubules. As you see here, SGLT1 is present in the intestine. So drugs that are less selective towards SGLT2 and can act partially on SGLT1 can cause diarrhea in these patients. So these are the differences. The glucose affinity is low in SGLT2 compared to SGLT1, which is high. At the same time, glucose transporter capacity is high with SGLT2 compared to SGLT1. This is why drugs created to act through this mechanism are directed to SGLT2, not to SGLT1. we have to know that the renal threshold is normally without diabetes is 180, the threshold at which glucosuria occurs. In type 2 diabetes, the renal threshold is elevated up to 240, and this despite having glucosuria, the renal threshold is high. This is why patients have hyperglycemia. Normal glucose filtering, glucose is filtered from the nephrons, reabsorbed 90% in the first segment of the proximal convoluted tubules and 10% in the third segment of proximal convoluted tubules, and passively through GLUT2 receptors present in the proximal first segment and GLUT1 present in the S3 of the proximal convoluted tubules. In type 2 diabetes, glucose transporters are upregulated and cellular glucose uptake is enhanced, as you see here in this slide. SGLT2 receptors are uptitrated and GLUT2 receptors are also upregulated in diabetic patients compared to healthy individuals. So we have a vicious circle with glucotoxicity causing sustained hyperglycemia, decreased glucose uptake, and the vicious circle of diabetes is established in this situation. We have to break this through the use of this group of SGLT2 inhibitors. This increased glucose reabsorption that can be seen in diabetics. In diabetics, as you see, the same mechanism that is in normal individuals, but the amount of reabsorption is increased and the amount of glucose excreted in the proximal convoluted tubules is increased. So finally, we have glucose in urine. Unlike in normal individuals, we don't have because of reabsorption. We don't have glucose in urine, but here we have glucose in urine. With the use of this SGLT2 inhibitors, the threshold for glucosuria is decreased even below normal. Normally it is 180. With the use of SGLT2 inhibitors, it is decreased down to about 90 milligram per deciliter, enhancing glucosuria in these patients, a mechanism by which we can decrease serum glucose level. We have EMPA-REG, Canvas, and DECLARE trial regarding treatment of type 2 diabetes and reduction of cardiovascular events. The difference in the design of these trials in EMPA-REG included patients with cardiovascular disease, Canvas including in addition patients with more than or equal 3 risk factors, and DECLARE patients with 2 or more risk factors. The follow-up was 3.1 years in EMPA-REG, 3.6 in Canvas, and 4.2 in DECLARE trial. 99% were known to have atherosclerotic vascular disease in EMPA-REG, 66% in Canvas, and 41% in DECLARE trial. Regarding renal impairment, 26 in EMPA-REG, 20% in Canvas, and 7% only in DECLARE trial. The placebo event rate was 4.4 in EMPA-REG, 3.2 in Canvas, and 2.4 in DECLARE trial. This is the outcome of EMPA-REG trial. We have 14% reduction of primary outcomes, cardiovascular death, non-fatal MI, and non-fatal stroke. 38% reduction of death from cardiovascular diseases, 32% reduction in death from any cause, and 35% reduction of hospitalization of heart failure. The MACE is reduced by 14% in EMPA-REG trial. Cardiovascular death and hospitalization for heart failure are all decreased in these groups of patients. Regarding Canvas trial, the primary outcome decreased by 14%, and hospitalization for heart failure is decreased by 33%. And MACE 14%, and cardiovascular death, hospitalization for heart failure also reduced. Regarding the DAPA DECLARE trial, dapagliflozin, the primary outcome is reduced by 7%, and hospitalization for heart failure or cardiovascular death is reduced by 17%. Number needed to treat in this trial was 39 patients. Regarding differentiation of patients with prior myocardial infarction versus without prior myocardial infarction, with prior myocardial infarction, we have more benefit in patients compared to placebo, as you see here, has a clear beneficial MACE outcome in high cardiovascular risk type 2 diabetes patients with prior myocardial infarction, and this is an advantage in patients with DECLARE. There is a significant 47 reduction in the occurrence of renal specific outcomes in DECLARE trial patients also. We have to remember that the cardiovascular continuum starts by risk factors leading to atherosclerosis, myocardial infarction, ventricular remodeling, congestive failure, end-stage heart disease, and death. So myocardial infarction is the key point in deterioration of the condition of the patients and of the transition of the patient from primary prevention to secondary prevention. In the DECLARE trial, for the first time, we have a secondary prevention benefit with the use of dapagliflozin in patients with diabetes. So in diabetes, we have primary prevention in patients with diabetes with multiple risk factors, and we have secondary prevention in patients with established cardiovascular disease that's documented in the DECLARE trial. In addition, we have renal protection, hospitalization for heart failure reduction, and major acute cardiovascular events in the use of this group of SGLT2 inhibitors. Okay, this is another Vertis evaluation of erogliflozin. This is another drug. However, this is the only drug in this group that failed to show a reduction in the primary outcomes in patients with diabetes. So, the management of diabetes have been for a long time glucocentric. Now, with the use of these drugs, we have changed the concept to reduction of major cardiac events rather than control of the level of diabetes itself. So, type 2 diabetes is a multi-centered disease with metabolic effects, cardiovascular effects, and renal effects. All of these have to be reduced with the control of diabetes. So with the control of diabetes, we have to control all of these factors. What the guidelines said, we'll see first the ESC guidelines in 2019 for treatment of diabetes and pre-diabetes in association with cardiovascular disease. Patients with diabetes have at least moderate risk if this diabetes is type 1 diabetes less than 35 years or type 2 diabetes less than 50 with a duration of diabetes less than 10 years without any risk factor. If we have a duration more than 10 years or any additional risk factor in the absence of target organ damage, the patient becomes high risk. In the patients with diabetes with established cardiovascular disease, any target organ damage, 3 or more risk factors, or patients with type 1 diabetes with a duration more than 20 years, this is a very high risk patient group. These guidelines for the first time recommended the use of these groups, SGLT2 inhibitors and GLP-1 analogs, to be the initial therapy for patients with diabetes without cardiovascular disease if they are not already on metformin monotherapy as the first line of therapy. And then if not controlled, you will consider metformin, and then if not controlled, we consider the other class, and then DDP4 inhibitors, basal insulin, and TZDs and sulfonylurea in series. While if the patient is already on metformin, so first thing to think is to add one of these groups, and in patients with, so this was the first time that metformin was removed from the first line therapy with diabetes, and this was a great surprise. The ADA after this came in the recommendation saying that in patients with atherosclerotic cardiovascular disease, first line, metformin and lifestyle. So they continued on metformin at first line, and then after this, if the patients have high cardiovascular risk, so first thing to prescribe is SGLT1 if the patient has atherosclerotic cardiovascular, established atherosclerotic cardiovascular disease. If the patient has heart failure, SGLT2 inhibitor, or after this, GLP-1 analogs. So these drugs came to be for the first line therapy for the first time according to the guideline recommendations based on these trials. The question is, does this effect extend to general population in diabetics? The DAPA heart failure trial showed that these drugs can be used to treat patients with heart failure, whether these patients are diabetics or non-diabetics, and this was for the first time to be reported. Also, the Emperor trial using empagliflozin showed similar effects with the reduction of events in patients with heart failure. So now we are facing anti-diabetic treatment that can be used for treatment of heart failure, either whether these patients are diabetics or non-diabetic. DAPA heart failure, we are waiting for ongoing other trials. DAPA heart failure published in December 2019, Emperor trial, Emperor preserved trial, and Soloist trial expected next year, and Deliver trial expected next year with dapagliflozin. The take-home message: cardiovascular protection in type 2 diabetes, focus on both MACE and heart failure. Multifactorial approach yield the highest risk reduction in diabetes. New anti-diabetic medications, GLP-1 analogs, SGLT2 inhibitors represent a fundamental paradigm shift in type 2 diabetes field. Since cardiovascular disease is the main cause of death type 2 diabetes, these data should shift focus on initial type 2 diabetes from hemoglobin A1C to cardiovascular and renal risk reduction. Cardiovascular outcome trials identified anti-hyperglycemic agents that are safe, superior for reduction of cardiovascular events in type 2 diabetes. Without the release of DAPA heart failure and reduced in patients with heart failure, reduced ejection fraction, we know that SGLT2 inhibitors can be used as one of the major anti-failure drugs for treatment of patients with heart failure. We are waiting for the results of the different trials using these drugs in patients with heart failure with reduced ejection fraction in non-diabetic population. We are also waiting for the results of SGLT2 inhibitors, particularly heart failure with preserved ejection fraction, in which most of other anti-failure medications have not shown hard endpoint effects yet. Thank you very much.